what this is. Okay. So we're going to talk about, let's see, I got to go like that. Preventing addiction-related suicide, or PARS. That's an intervention that we studied, but it also is a comment. How do you prevent addiction-related suicide, and what the heck is addiction-related suicide? So suicide, if you look at all the people who do grants in suicide and you look at who's written what, you find that it's about 95% people that are psychologists or psychiatrists and that are in the mental health field. But if you actually look at predictors of suicide, addictions are just as high, if you will, as a risk factor for suicide, as actually greater than major depression and somewhere between major depression and bipolar. But the other thing about addictions is they're a lot more common than either one of those disorders. The top little bit of data, alcohol was the strongest predictor of completed suicide over 5 to 10 years after a psych hospitalization. So they followed up a bunch of people in an inpatient unit over in Philadelphia. And they followed them 5 to 10 years, and they looked at who actually killed themselves after the admission for suicide. And alcohol was actually the strongest predictor, more than psychiatric diagnosis, more than demography, or any other factor they could study. A summary study done in 2001 that looked at completed suicides across the USA, Europe, et cetera. And they figured somewhere around 50% of people who actually kill themselves, alcohol or drugs is a significant factor, or direct factor or associated factor. The last study done by one of my mentors, Mark Shuckett, was a genetic study looking at alcohol, and he was comparing people with strong genetics for alcohol dependence, and he compared about 1,000 people that were matched demographically and every other way he could figure out, and followed over 5 years to the primary aim was actually to look at alcohol related issues and relapse and use and things like that, but they also studied suicide. And in the people who were age and sex and demographically matched, the people who had alcohol dependence at first, compared in every other way to those same group, had a 700% increase. So remember that 7, because if you were to look at a dozen other studies that have followed people over time or looked at big epidemiological studies, what you find is people with severe alcohol use or dependence have a 5 to 10 times chance of making or completing a suicide attempt, and 7% or 7 times recurs study after study that you see done in this country or other countries. So here's one from Denmark, following 18,000 people over 26 years, 8-fold increase in suicide deaths among those with alcohol use diagnosis compared to those without. So there's that number again. Now, something that's really come along, a lot of the initial work around suicide and addictions studied alcohol, because alcohol has been around in large numbers for many years across cultures, et cetera. But in the United States, over the last 20 odd years, we've had an opioid epidemic. And so now we have opioid related death. And opioids, of all the substances, have the highest death rate of any psychoactive substance. There are about 42,000 in 2016, 80,000 opioid overdose deaths in 2021, and about 100,000 opioid deaths in 2022. The change of that over time with increase is both the expansion of the epidemic, but also the addition in the last 5 or 6 years of fentanyl. And I think you all know what fentanyl is. It's a synthetic opioid that's 50 to 100 times stronger than heroin, and also very cheap to make, made in huge labs. How many of you watched the show Breaking Bad? Raise your hand. Well, you saw how the methamphetamine was eventually concocted in this huge industrial sized stainless steel vats and everything, and produced by the pounds rather than the ounces. And that's what fentanyl is doing now too. Fentanyl is made and shipped in huge containers. The mortality rate of people that are opiate users is 14 times that of the general population. About half to two-thirds of opiate users experience one or more non-lethal overdoses during their lifetime. Certain opiate users who are released from prison are at super high risk of overdose because they come in with a higher tolerance. They lose their tolerance if they're not treated with buprenorphine or anything else. They leave and they use some amount of opiate, usually fentanyl now, and they don't have very much tolerance compared to when they went in, and they end up overdosing accidentally. Now, one of the issues you start finding out, and I've treated many opioid addicts, people with addiction to opioids, people who started out to just sort of use a little bit. The next thing you know, they are daily heavy users, and especially with fentanyl. One of the reasons fentanyl is so lethal, and so effective at dissemination, if you will, is unlike heroin, where you could snort it, you could smoke it, but fentanyl a lot of it comes in pills, and you can take it orally, you can put it under your tongue, you can chew it up, you can do a lot of ways. So the whole stair step resistance to becoming dependent on opioids, the old needle and heroin, where people said, well, I'll use stuff, but the idea of using needles, that's just another, I can't do that. Well, you don't need to do that with fentanyl. It's strong enough that if you smoke it, you can be just as high because it's more effective at crossing blood-brain barrier. Now, I created this slide many years ago when I was starting to treat opioid addicts with Suboxone or buprenorphine. Everybody knows what Suboxone is, right? Buprenorphine. That's one of the opioid replacement meds that we use to stabilize the opiate receptor in people who have opioid dependence. So what I noticed when I talked to my patients, who virtually almost never has a straight line to people in getting better. There's always a few bumps in the road, a few relapses, etc. And talking to people about their past, it occurred to me, it's very obvious that sometimes if somebody had 5 overdoses in their past and they've been using for 5 years, they would say, well, yeah, out of those 5 overdoses, 2 of them were absolutely fully accidental. I had no idea, and I must have just run into something that was really strong. A couple of them were, I knew I was using more, and I used it just to blot out thinking and worries. My life was going in a bad way. I felt crappy about things. I couldn't stop using. I sort of didn't want to stop using it. I couldn't stop using. I sort of wanted to stop. And so, bad things happen. My girlfriend left me or whatever happened. And I just used like twice as much and to blot out the worries. And I'd done that before, but this time I like woke up 2 days later in my apartment. I'd been like out like for a day or two. That was just to blot out worries. And then other people who'd had some blot out worry stuff Oh, when I knew I was using more stuff, I really, I wanted to blot out words, but I also didn't really mind if I didn't wake up, because who cares if I wake up? There's really nobody who cares when I wake up. Most people that I used to know who did care about me have abandoned me because I stole stuff from them, or they couldn't stand the way I was living. So there's really nobody who cares, and I don't really care if I wake up. And then they might say, well, there was one or two times where actually I had a lethal plan and I used like 5 times as much. And man, that one, I woke up, I've been laying on my arm. I could barely use my arm because I've been laying on it. I was in my apartment. I'd been out for 2 days. I tried to kill myself, but I guess I just didn't. So this whole issue of where accidental overdose begins and ends, and lethal plan begins and ends, is a sliding kind of line like that. So if you look at increased suicide risk, major depressants about 6 times chance of a lethal suicide, alcohol 5 to 10 times, opioids about 14 times. Meth is a little funny question mark because so many of the opioid and the meth overdoses are involve multiple drugs. So it's almost never that you find somebody overdoses just on meth. They just get higher and higher and higher. Sometimes if they use a lot, they'll get a heart attack. But most meth overdoses are combined with opioids. So a lot of things lead to suicide. This is a do how many of you know Amanda Kerbrat? Amanda was a very key part of the PARS study. Amanda is a very important person to me. And she and Adam, who were the people who sat in on all the sessions I did training the counselors who did the intervention with PARS. She's not only an incredible statistician and study designer, but she has been a clinician for many years. And so anyway, she created this slide, and I like this slide of how all these different kinds of things. If you have a substance use disorder, just the use itself can alienate people and invade your life. Withdrawal can be painful and awful. Being impulsive, if you start impulsive and you use drugs, you usually become more impulsive. Life problems that are created when you use, very common. You can see people with a super life problems if you drive around Seattle or any other big city, and you can see people that have pretty much ruined their lives. Their entire life fits in a box or a bag. Depression and anxiety, they started with depression or anxiety, or because substances cause both depression and anxiety, either in their intoxication form or the damage they do, as AA says, the wreckage of the past. All of those things. And then there's that funny little thing at about 11 o'clock on the thing, accidental overdose. And so the suicide numbers that we get out of the American Foundation for Suicide and other places, nobody quite knows how to figure out, out of those 100,000 opioid related overdoses, how many of them were on that spectrum that I showed you? How many of them were partial or full or mostly accidental or mostly on purpose? So there's probably a whole lot more evidence of suicidality in those figures than is necessarily evident. So we're going to talk about PARS, preventing addiction-related suicide. PARS is a group-based suicide prevention model designed to, with and for community attention, addiction intensive outpatient program. So how many of you have ever worked in a community addiction treatment program? I can't see all the hands. I don't know whether any of you have. But if you look at the treatment structure in the United States, everybody knows about mental health centers. Well, sort of the equivalent of mental health centers are community addiction treatment centers. And they're about a third as many community addiction treatment centers as our mental health center, but that still means thousands, literally. And the way a community addiction treatment center is set up is their payment is about a third of what it is for treating a mental health patient. And the model for treatment in community addiction centers, and we're not talking about opioid treatment, we're talking about treatment for various addictions or people dabbling with opiates, but primarily people with alcohol, marijuana, and stimulants. People who need treatment for opioid dependence fairly quickly figure out that talk therapy for their disorder isn't enough, and they're going to need to be in a buprenorphine program or a methadone program. So there's about 2.6 million, there's about 2.6 million people a year go through community addiction treatment. And in community addiction treatment, 80% of the FTE, the amount of time that somebody spends in treatment, is in groups, and they're in IOP. So if you get a DWI driving down I-5 and you drank too much at the party, and you've been starting to develop an alcohol use disorder and drinking too much too often, and the judge sentences you to treatment, you're going to go to a community alcohol treatment center. And in that center, you may or may not get an alcohol medicine, probably not. But the primary thing you're going to do is meet with a counselor about once a month, and you're going to go to group 3 times a week. And then that group is about 3 hours long. And it happens 3 times a week for 3 months, and then 2 times a week for a couple of months, and then once a week or so, or once every 2 weeks for the rest of a year. So you actually get a year of treatment in IOP, which is intensive outpatient program. And it's primarily group therapy led by counselors. Having met a lot of counselors and trained a lot of counselors as part of PARS, most counselors are very skilled and are really good at what they do in terms of leading groups and helping people change by learning from each other in groups, facilitating group change. So why did we create the PARS? Well, so I'm going to say just a little bit more. I'm going to get around to how I got decided to do PARS. It's a 2 or 3 hour PowerPoint-based interactional group module designed with and for tested community addiction treatment centers. It was designed to fit into a single 3-hour IOP session and include, I'll get to the 900 patients in a minute. But back in the early 2000s, because I've always been interested in both addictions and in suicide. You know, if you're an inpatient doctor, you're interested in suicide because half the patients who come in related to suicide attempts or being intensely suicidal. And half the patients who come in have an alcohol or drug problem too. So it's pretty natural I would be interested in this. So I said, well, you know, we should figure out something that addiction centers can do around suicide prevention. And I'm a lucky person. So I've been around Kate Comtois for the last 30 years, and I was around Marsha Linehan for 10 years in studies that were going on over there. So I know a little something about suicide treatment. So I created a work group of suicide experts, and then a work group that included 3 people who run community addiction centers who, by hearsay and around we're interested in kind of psych issues with patients and suicide issues with patients, and we're sort of interested in this area. So our work group got together, and we first the addiction experts got together, and we said, well, you know, they have all these group therapy things. If we could design something that fit right into their group therapy thing, wouldn't that be good? Couldn't we do suicide prevention there? And we all agreed to that. So we went to the administrators of the programs. Those are the people who get budgets and have to fund them and all of those kind of things, the reality people. So we said, well, we'd like to develop a 5-part suicide prevention module that you get to put in your IOP, and we'd love to do that. And they said, great, you get 1 session. And I said, well, how about 3 sessions? And they said, well, that sounds good too, but you get 1 session. And we said, well, hold on, how can we get 1 session? How come it's just 1 3-hour session? And they said, well, actually, if you look at the state law, since people are often from DWIs and work-related things kind of sentenced to get IOP, it's actually defined in the state legislature under RCW, the administrative code. And there's something like 32 items that have to be covered in IOP. And so if you look at all the topics that have to be covered, things like the family and alcohol, or the family and addiction, or cocaine in the brain, or all these kind of things that are actually specified by law, we have one that is flexible enough, and it's about mental health issues, that we could stick the suicide thing in there. But we can't just take 5 sessions and displace this other stuff, because we'll get audited and busted for that. So you can get away with something that's a single session. So we developed a single session in preventing addiction-related suicide module that we developed with suicide experts, including Kate and myself and some other people. And we worked with the administrators and frontline chemical dependency workers. And we changed the language, and we changed this, and we changed that. We made it usable for people in that setting to get go. And we said, well, okay, how are we going to do this? And one of our people, Dennis Donovan at the time, said, well, we should have these big charts. And I said, well, hold it. What about PowerPoint? Now, this was back in the early 2000s, or 2008, 9, 10. And the whole idea of computers and PowerPoint being part of treatment was a pretty new idea. So I said, well, let's develop them on PowerPoint base. Because that way we have a lot more control over it, and we can change it over time, and people, so we developed a PowerPoint, and the idea of having it on a PowerPoint was also around the issue of fidelity. If we develop this intervention, and again, having worked with a community addiction center, the one that actually exists at Harborview Mental Health Center, the Mental Health and Addiction Treatment Center, has a community-based addiction treatment center. So I saw patients in that, and I worked with the staff of that and all that. So I could see, if you look at the books that the community addiction treatment staff use when they do groups, they're this conglomerate of things that have been stuck in there over time that the leaders of the group find helpful. And I said, if we just sort of put this thing out there, it's going to get adapted, and people are going to do, well, I like the first part of it, but not the second part of it. So you all probably know what I'm talking about. How do we keep people on target to do an intervention when they kind of naturally want to stray off this way or that way? So we developed this iteratively, this PowerPoint intervention. And that's how PARS was developed. It was developed with community addiction centers. So then the issue is, if you're going to do a prevention thing, well, first of all, let's say, well, if you develop an intervention, first of all, you got to show that you can actually do it in a community addiction center. So we went to those 3 addiction centers that helped us design the PARS and said, no, you don't get 3, you don't get 5, you get 1. We went to those centers with the PowerPoint module in PowerPoints that we had developed. And we got a NIDA R21 treatment development study. And Bill Voss, who's the lead director, I had him be the primary author. I like to give my staff primary authorships. And we showed that in the community, given this without a control group, that we got significant changes in knowledge, attitudes, and coping skills. Not only that, but the staff told us when we were doing this, the staff said, you know, I love this PowerPoint format. I wish the other stuff that we do in our talk, because most of the studies would have like a learning session for half the 3-hour session, a short break, and then a discussion section of whatever people were thinking about, or what do they think about the learning session that they had first. That's kind of the structure they used anyway. So they said, we really like this thing. So we got the study, we published it in the Journal of Substance Abuse Treatment, which is a top-line addiction journal. And that was back in 2013. We had gotten a grant, I think, around 2009. We did the pilot study for a couple of years. We analyzed the results. We submitted to a journal, and all of that basically takes about 4 or 5 years to do, even if you're pretty trim and fast about how you do. So, so we talked to, and Kate Comtois, who, if she wasn't around, there's no way I would have done any of this. And same way with Amanda. And same way with the wonderful technicians who did all this. So we had to come up with a model. How are you going to show that a group therapy intervention works? Now, if you look at the world of treatment, you'll find almost no data for group interventions. There was some study of group interventions 30, 40 years ago, but there's almost no study of group interventions these days. And one of the reasons is it's hard to study group interventions, because what are you going to compare it to? You got to find another group. The groups have to match. And instead of, like, if there's 10 people in the group, in an individual study, you can study 10 versus 10 or 100 versus 100. But if you use groups, now the groups, now you only have 10. You have 100 people and you have 10 groups. Now, how are you going to get enough groups to do a study of an RCT comparing effectiveness of one to the other? So Kate and our methodologists worked together and decided we could get away with 15 different IOP sites if each of the sites had 3 different groups. We also developed what I call a usable training model, where I would go to the addiction center. I would run a group with the exact PARS slides, and the CDPs, that is the counselors who were going to do the intervention, they were patients. So I was the therapist, they're the patients. They experience the PARS program from the inside out. Then 2 weeks later, they do the PARS intervention with their actual subject patients. And in the meantime, one of our technicians, Adam or somebody else, goes and gets permission, does consent, takes baseline measurements of the patients and all that. And then they're assessed 1, 3, and 6 months after the intervention. And since this is 15 different IOP sites all over the Puget Sound area, all the follow-up is done via interactive phone, digital kind of stuff. We ended up with almost 90% follow-up. So that was really good. So that's what the stepped wedge design of the study looked like. And each of those steps is 3 months. So when you start out, you do baseline over all the 5 different centers with 3 sites each. Then on step 2, one of the sites with 3 groups gets the PARS, but they're comparing themselves with those other 4 groups, both directly below them. The next step, which is now 6 months later, the PARS, there's 2 PARS groups going on at sites 1 and 2, and they're comparing to the other 3, and it goes on. And that's the way stepped wedge works. So these sites, because there's flow through of patients, are at times having the PARS going on, at other times not having the PARS going on. And you're comparing people who get PARS to people not who get PARS. And we did that with 15 different sites. There were actually 100 counselors trained, because counselors come and go too. In the intent to treat analysis, what we showed is, in fact, patients who had the PARS had a greater improvement in suicide knowledge. They had greater reduction in maladaptive suicide attitudes. And those improvements were maintained at follow-up, with a high rate of follow-up. And from baseline to 6 months, there was a greater improvement in help seeking in the PARS. Help seeking, by the way, is really hard to measure change in. You probably know this if you've done other research. There's even articles about the problem with trying to define what help seeking is or how to define it. So we used it as a variable because it had actually been very positive in the pilot study. It was a little harder to measure in our study, but it came out significant at 6 months. When you excuse me, and when you do an intervention, it's great to have it work at 6 months. So how do we get there? I first was interested in this as a clinician, and we started doing dual diagnosis, meaning mental health and addiction groups, back in '82 on inpatient units. We developed dual diagnosis outpatients at the mental health center in the early '90s. I continued to do inpatients and see them. I was the leader of CSAT TIP 92, which is about addiction and mental health issues, and again at TIP 42. We did the NIDA pilot study in 2009, not 2005. Then the NIDA randomized control study in 2016, and that led to a publication in JAMA. We then got a grant from the Garvey Foundation to study, to develop a dissemination web training. Now, probably all of you know this, or maybe you don't know this, but there are estimates that about 90+% of all the interventions that are funded by NIMH or NIDA end up on shelves and never end up in the community because they're unrealistic study. They use particular patients that are clean, and in the real world, patients aren't clean. Patients have 5 things wrong with them, or 3 things wrong with them, not just one. They They rely on highly trained interventionists that don't exist in the real world. So the way we did PARS was we made it so that the actual counselors who were doing their treatment, their IOP treatment, they're the ones who got trained, and they got trained in a single 3-hour session to do the intervention. When they did intervention, it worked. Patients liked it, counselors liked it. So me being a clinician at heart, we really started PARS at the distal end of things. And so that's the effectiveness in it. We weren't back toward efficacy. So it's a very different design than most studies. We made it to try to be disseminated. So the Garvey website, so there's the pilot study. We also studied counselors' ratings, and Kate just did a publication that's been accepted in JSAT on the counselors, like, yeah, and you can see all the very positive scores, effectiveness, acceptability, perceived effectiveness, incorporating PARS into their intensive program. So again, no intervention is going to work if you try it and people say, well, I love it, but there's no way it fits into what I do day to day. What we found with PARS is it would be a natural single session of IOP, and people would like to do it. So there is a way to get PARS training. PARS is not yet fully disseminated yet. The next step for me is getting the PARS access. It's all made up and works. I'm going to show you it in just a minute. But the next step is working with the state, working with the unions of chemical dependency workers and addiction treatment sites to start integrating PARS into themselves. So I'm going to change over to what? Can everybody see this? Okay. So this is a self-training PARS web, and you can get the slides for PARS for nothing. You can just download them. But if you want the advanced training, which we made with Garvey funding, not only includes all kinds of directions that are written for counselors who, if they're doing this, but it includes videos of me actually doing the intervention around certain key slides. Take care of that. What am I doing? Okay, so if you're going to do the PARS somewhere, in case somebody actually defines somebody during a group session, somebody says, hey, I've been having pretty active suicidal thoughts. You want every place that trains for PARS to know what their policies and procedures are around PARS. So these PARS slides include all kinds of pre-PARS information. Julianne, if you're still on there, how do I get rid of this side panel of pictures?
Good question. Do you mean like the menu nav on the left?
No, on the right, I'm seeing the pictures of all the people. So, and they're covering half the slide.
Yeah, can you click on the box and just drag it over? or minimize it. There's,
Oh, okay. Okay, there we go.
got it, perfect.
So the first part of it is preparing for actually doing the intervention. Then, so that I'm just going through this really quickly because we're low on time. But so the preventing suicide intervention now sort of prepares you to do the intervention. And then it tells you what's in it. Um, it has counselor notes on certain things, not counselor notes on other things. So this is where things really start here. So one of the things you do when you start this intervention is educate people about suicide. Most people have no idea that suicide is actually much more common than homicide. You would never know that. So we have some data that's right there. And so, for example, in this particular slide, the data slide, if you go to counselor notes here, it sort of talks, if you're learning how to do this, it talks about the key issues related to things. Then, for example, comments like this, because we had people sit in with the groups, we know what kinds of questions come up with people. So in this one, for example, this is one of the best slides in the whole thing. How many of you know someone who's died or nearly died from a suicide attempt? Was this alcohol or drug related? You go around the room with the people that are part of the group and they talk about this. And in all the trainings we did, there were maybe 5% of the people didn't raise their hand and didn't know somebody who had a death by suicide or nearly died by suicide. And most of them had an alcohol or drug related, some of them didn't. But it got a chance for somebody to share that with other people and to understand other people have these experiences themselves dealing with somebody else who died by suicide. And then, of course, that means they're starting to think about themselves too. In this one, for example, there's a video. If you're doing the web training, so the whole set of the videos actually include knowledge. They start addressing attitude. They try to start addressing coping skills later on in it. The first part of this is all about information, and that, did you know somebody who committed suicide? That gets people paying attention. Instead of eyes wandering around, you see people very interested. Well, there's about 60 slides here, so I'm not going to go over them. We're out of time now, but we have time for just a one or two comments from people, and I'm interested. I'm sorry we don't have more time, but it's a big area to cover, whatever, 25, 20 years of development. So thoughts, comments?
I have a question.
Sure.
Yeah, my understanding is that of the 15 IOP sites, they were not all under the same organization. There were multiple community addiction treatment organizations.
Yeah, there were 50. There were 5 main different centers. Yes.
Okay, and were there any differences or challenges implementing PARS across sites, or was it pretty similar across those different sites?
Interestingly enough, it was actually pretty similar, although the organizations were hugely different. Very, very different. The organization down in Tacoma had a whole lot of opioid addiction in it. The center in Everett had participated in other CTN studies in the past. The one that had the actually most sites was Lakeside Milam, which is a very private addiction treatment center that had never participated in any kind of study, but the administration of it, and they had 9 sites, was super positive on it, and the administrator for it really helped it all happen. So the sites were different, but the challenges were overcome, and Adam, and chiefly our main outreach person was Adam, and he was just so good at going to sites and getting them engaged and getting them sort of educated up, making sure their computer system and their PowerPoints, their ability to show PowerPoints was going to work. Because back in those times, the mid, like 2018 or something like that, people's computer systems in community addiction centers were just sort of getting a little better. Other thoughts, questions? Okay, well, I think we're about out of time. Thank you all for listening. I know it's a lot of stuff, but I was trying to show you how a clinical idea can then become a research idea, which then can become a research intervention, which then can become a study, and then the dissemination is where we're in that stage right now.
Thanks a lot, Rick. Yeah, I think it's, we really are going to